You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is May 7, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, Immunologic Endocrine Disorders. Our presenter is Dr. Mark Clements. He's a pediatric endocrinologist at Children's Mercy Hospitals and Clinics. So welcome to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. We're joined this morning by Dr. Mark Clements. Dr. Clements is are you an assistant professor? Okay, pretty soon you'll be associate, I have no doubt. But Dr. Clements is currently an assistant professor in the section of endocrinology, and he's agreed to talk with us this morning about immune endocrine disorders. I think this is like the third year you've done this?
Just the second.
This is the second one? Okay. Wow, because it's always informative. I really get a lot out of your presentations. So I really appreciate you coming today. And without any further delay, I'll go ahead and turn the podium over to you. Here's a wired mouse or a wireless mouse. It's your choice. And let me just pull up your PowerPoint. So thank you for joining us today, Dr. Clements.
Absolutely. Thanks for the invitation. The first thing I will say is that we'll keep this rather informal, so if you have questions along the way, please do ask. I know that the people in the room here have done some reading prior to the lecture, so we can let your questions guide us as we go along. This is not going to be a comprehensive lecture on autoimmune endocrine disorders because that might take us more than an hour. But I think that we'll cover some of the salient features of the major diseases that we see with some frequency. So the first thing just to think about with all autoimmune diseases are the mechanisms and the breakdown of tolerance. And we won't go through that in great detail, but I just want to bring them to the forefront of our minds as we go through. So we have failure to delete autoreactive lymphocytes. We have central tolerance failure under that, peripheral tolerance failure. We have molecular mimicry, abnormal presentation of self-antigens, aberrant expression of MHC, coupling of self and non-self antigens, overproduction of self-antigens, neoantigens, which is a really an area of great interest right now when you think about diseases like Alzheimer's or type 1 diabetes or Friedreich's ataxia, where oxidative damage can occur to proteins, DNA, and lipids to create antigens that the immune system may be naive to. Disclosure of cryptic T-cell epitopes, release of sequestered self-antigens, and epitope spreading. Polyclonal activation. Okay, so just to briefly mention molecular mimicry, you all probably know a lot more about this than I do, but if you look across peptide sequences from proteins in a number of viruses that human beings are exposed to, as well as a few bacteria, you see some significant sequence similarities in certain peptides. And so, there are obviously hypotheses for a number of autoimmune diseases that this molecular mimicry may, in fact, trigger autoimmune events. Looking at autoimmune endocrine diseases, we'll talk today about the thyroid, including Hashimoto's, Graves' disease, and the brief mention of neonatal Graves' disease. We'll talk about the pancreas and type 1 diabetes. I'm going to save that for last because it's sort of a big topic, the area in which we have the most research. And those who have experience in the adult world will recognize LADA as latent autoimmune diabetes of the adult. And this is, it used to be considered a distinct entity from type 1 diabetes, but now we really think that type 1 diabetes is a lifelong illness. It's not juvenile diabetes. It's autoimmune disease that may occur across the lifespan. So these two entities are really part of the same complex of disorders. In the adrenal, we have Addison's disease. In the gonads, autoimmune oophoritis and orchitis, which generally occur as part of polyglandular autoimmune syndromes most commonly. And then lymphocytic hypophysitis, which we don't see in kids really ever. I think there are a few case reports, but the adult endocrinologists do see. And then polyglandular autoimmune syndrome. So if we talk about thyroid autoimmunity, hopefully you all know that Hashimoto's disease represents autoimmune hypothyroidism, and Graves' disease represents autoimmune hyperthyroidism, and neonatal Graves is not autoimmune disease of the neonate, but simply the passage of IgG antibodies from mother to infant, and it's a self-limited disorder. As those antibodies are cleared, the disease calms back down. The infant has the same baseline risk for Graves' disease that any other family member would have. So Hashimoto's thyroiditis does have a disparity between sexes, with females having higher risk associated with HLA-B8. And hopefully you all know that there are two pathognomonic antibodies for it, the thyroid peroxidase and thyroid globulin antibodies. You can also have anti-TSH receptor antibodies that are blocking antibodies, and this can make the picture somewhat confusing at times because, for instance, with neonatal Graves, if a mother has thyroid-stimulating immunoglobulin and has anti-TSH blocking antibodies, that infant could present with neonatal Graves, thyrotoxicosis, or could present with hypothyroidism in the neonatal period. So Graves' disease is less common than Hashimoto's disease, although we still see it quite frequently. I would say we have about one new pediatric diagnosis every 2 weeks in our clinic. And again, an even higher predilection for females. Still the same HLA association. And there's an association with Hashimoto's in that you can have Hashimoto's and Graves' disease in the same family. The mechanisms by which they occur are thought to be the same. The autoimmune mechanisms are thought to be the same. The only thing that distinguishes them is the presence of thyroid-stimulating immunoglobulin in Graves' disease, which is just a special autoimmune antibody that stimulates the receptor.
Do we know why they get the exophthalmos?
Yeah, there's some inflammation in the extraocular muscles.
Really? The people with that disease, they always look very intense. They're looking, absolutely. They're staring at you, and like somebody that you might know is Alan Luskin. He has Graves' disease. He was treated, but his eyes are still really big, so he looks very intense when he talks to you. He actually is a very intense person too, so it kind of goes along with it. But very interesting.
You probably don't need to see this, but this is just a small diagram showing that TSH binds the TSH receptor to stimulate organification of iodine to create T4 and T3, the thyroid, major thyroid hormones, and you can get stimulation by an anti-TSH receptor that mimics the effect of pituitary stimulation. So in Graves' disease, you would expect that the T4 or free T4 would be extremely high, and that the TSH in this case would be very suppressed, undetectable. We actually had a case in the emergency room last night. And this is a true endocrine emergency when that happens, because if you think about the symptoms, exophthalmos is a late symptom. but you get tachycardia, whitened pulse pressure, you can have thyrotoxic storm, seizures, elevated blood pressure, things like that. This is just to mention that there can also be blocking antibodies that occur. So clinical features of Graves, agitation and sleep disturbance, sweating and palpitations, proximal muscle weakness is quite common, hyperdefecation, essentially diarrhea, weight loss despite having a voracious appetite, a goiter, so if you palpate the thyroid, it'll have a beefy texture and will be enlarged. Tremors, so patients complain a lot of movement. They're fidgety. So when they walk in the room, you know they have Graves' disease before you even do a test because they're just constantly, it's almost like they have a choreiform disorder. And then the ophthalmopathy, dermopathy, and you can get some findings in the digits as well. Okay, so let me just pause there and mention Hashimoto's disease. So Hashimoto's symptoms are going to be exactly the opposite of the Graves' symptoms. So you're going to have fatigue. You can still have dermopathies. You're going to have a slowing down of everything. So the patient isn't going to have any tremors. In fact, they're going to feel really sluggish. They're going to possibly feel weak. They may be gaining weight. They're going to be constipated. So everything just slows down.
Aren't they cold too?
They're cold also, yeah. And with Graves, you can feel hot. So when everybody else in the room is comfortable and you are cold or hot, you think about one of those disorders. Addison's disease occurs from the deficient production of adrenocortical hormones. Remember that there are three major hormones produced by the adrenal gland. You have cortisol or glucocorticoid, you have aldosterone or mineralocorticoid, and you have testosterone. And the symptoms of Addison's disease are weakness, anorexia, nausea, vomiting, weight loss, hypotension, and can be associated with those HLA haplotypes and pathognomonic or 21-hydroxylase autoantibodies. Does anybody know which American president had Addison's disease?
Kennedy.
Kennedy. Sorry.
He always looks so tan.
Yeah. So, and just to remind you, the reason that you look tan, of course, is that if you're not making the primary antibody, you have to go back up to the pituitary. So you think of all the primary endocrine organs as furnaces. That's the way I like to think of them. So the thyroid is a furnace, the adrenal gland is a furnace, and the pituitary is the thermostat. So if the furnace is not burning hot enough, then somebody comes in and turns up the thermostat. So what happens in that case, in the case of Addison's disease, is you start producing a lot of ACTH. But the problem is that ACTH is produced as a part of a multigenic transcript, pro-opiomelanocortin, and so you also end up creating melanocyte-stimulating hormone. There's no association with race in the case of Addison's disease. It does tend to be more common in females and bump in the onset among children. And in adults, the most common age is 30 to 50 years. It can present earlier if they have polyglandular autoimmune syndromes or congenital adrenal hyperplasia, or if the onset is due to long-chain fatty acid metabolism. So not all primary adrenal disease is autoimmune. So if you have defective long-chain fatty acid metabolism, you can get it. If you have congenital adrenal hyperplasia, you can get primary adrenal failure. It's probably important to note that the symptoms of primary adrenal failure are different than the symptoms of secondary or tertiary adrenal failure. So secondary and tertiary adrenal failure occur if the pituitary or the hypothalamus are not regulating the axis appropriately. So in those cases, you will have a deficiency of glucocorticoids, but you generally don't have a significant deficiency of mineralocorticoids. You may have a slight deficiency, but not enough that you waste salt. So that distinguishes the two entities: primary adrenal failure, you waste salt, and you need mineralocorticoid replacement. So on mortality and morbidity, they're usually due to a failure in making the diagnosis in an appropriate time frame, or to institute both glucocorticoid and mineralocorticoid replacement. Acute Addisonian crisis can result in death from hypotension, hypoglycemia, seizure, cardiovascular failure from either of those. It could occur acutely, for instance, in the presence of an adrenal hemorrhage, but in Addison's disease, it may be superimposed on the chronic disease. These patients, if they have any stressor, that stressor could be a fever, it could be respiratory distress, like an asthma flare-up, it could be pneumonia, it could be a broken limb, it could be emotional distress, like an argument with a parent or a breakup with a boyfriend or a girlfriend, and they can trigger an Addisonian crisis. And in those times, the patients have to increase the dose of glucocorticoids. So usually we tell them to double or triple the dose.
Yeah, that's kind of an issue that occasionally comes up in terms of how sensitive are they to stressors. Are stressors really that stressful, and is it enough stressful to supplement and so on?
Right.
It comes up in patients who've been on oral steroids for a period of time to treat their inflammatory disease, and then you wonder, do I need to supplement them or not, or whatever. How much stress does it actually take to trigger an Addisonian crisis? Is it easy and at the top of the head, or is it?
No, I mean, yeah, you're going to find that probably 90% to 95% of kids who had a fever, for instance, and whom you did not increase the steroid dose would muscle through that disease just fine for a week. But it's the 5% that you worry about. So that's why everybody needs to be treated.
So you can't really predict it, but because there is that risk and because supplementation is fairly benign,
correct,
might as well do it. Is that the logic?
That's exactly right, yeah.
Okay.
And it makes physiologic sense. So when we're stressed, you can look at our cortisol levels and they go up. So that's the nice thing about endocrinology, is that everything either goes up or goes down. There's really only two directions to it. Let's see, what else was I going to say? The other thing I find is that there are certain stressors for which we always treat. So a fever and respiratory distress would be two. But some kids who are in emotional distress may not have any issues, and some kids who have emotional distress may find that that's a significant distressor and have a hypoglycemic episode during it. So, of course, primary adrenal failure is most commonly caused by autoimmune disease in the U.S., but that's not the most common cause worldwide. Does anybody know what the most common cause worldwide is? Tuberculosis. That's right.
Tuberculosis? Oh, because it infects the adrenal gland themselves.
So you get lymphocytic infiltration and fibrosis with sparing of the adrenal medulla. The clinical presentation is usually insidious, so hyperpigmentation, which we already mentioned, but it's a unique hyperpigmentation that also involves the mucous membranes and the palmar creases. So you'll be able to look at their creases and see that they're hyperpigmented as well. You may see vitiligo. Very interestingly, our patient in the emergency room last night who presented with Graves' disease also had vitiligo, and so you start to think about polyglandular disease in that case. In this case, we already discussed that, the hyper-ACTH secretion. So, increased among females and has its own HLA susceptibility genes, DR3 and DR4. So again, dizziness with orthostasis may be the result of hypotension, myalgias, and just feeling like you've been hit by a truck, with muscle paralysis intermittently, progressive weakness, weight loss, fatigue, poor appetite, and GI symptoms. So if the patient comes in vomiting and hyperpigmented, that's pretty much pathognomonic for an Addisonian crisis. So the way we test the hypothalamic pituitary adrenal axis to diagnose this disease is with a stimulation test. Endocrinologists don't just like to draw blood, they like to make it really fancy. So we do a lot of stimulation testing for most hormone axes. And in this case, we give synthetic ACTH in a dose of 250 micrograms. You may see, if you look through any of our past notes, a low-dose ACTH stimulation test. The low-dose test uses 1 microgram and is in practice in some places in the world. We were using it, but there are a few papers that have come out that suggest that you may overdiagnose conditions with the low-dose stimulation test, and so we've really abandoned it for this high-dose test. And so you get baseline cortisol and aldosterone levels, and then 30 or 60 minutes after the ACTH injection, we use 60 minutes here, you draw additional labs for cortisol and aldosterone. And so to interpret it, you have to have 2 criteria. The cortisol value has to rise of 7 micrograms per deciliter or more, and it must rise to a total level of 18 mics per deciliter or more in order to exclude the condition. In patients with Addison's disease, true Addison's disease, you get almost no change in cortisol. So they may have a level of 1 to 4 micrograms, and it just doesn't change at all. When the results of the rapid ACTH testing don't meet the criteria above, that's when we turn to antibody testing to try to distinguish between Addison's disease and secondary adrenal insufficiency. Of note, the test, actually, the stimulation test actually tests for disease of the adrenal gland, disease of the pituitary, and disease of the hypothalamus. So it can be primary, secondary, or tertiary. And the reason that it works is that if the adrenal gland does not get continued stimulation from ACTH over time, then it atrophies. And it takes a lot of stimulation over time to get it to produce hormones again, to engage in steroidogenesis. So as long as you have chronic adrenal failure, it doesn't matter where in the axis it is, you'll catch it with this test. So we manage these patients by replacing glucocorticoids and mineralocorticoids. The patients should be monitored for over-replacement, and we should be monitoring at least during their teenage years for osteoporosis when on maintenance steroids, and then they double or triple their dose. As an interesting side note, people often forget that patients with this disorder could have other endocrinopathies like diabetes insipidus, and there's a really important interaction between your steroid dosing for adrenal failure and your diabetes insipidus, because glucocorticoids will increase cardiac output, therefore increasing free water clearance of the kidney. If you're on a dose of DDAVP and you are stress dosed with steroids, you may find that your sodium goes up and that you become more dehydrated, and so you need more DDAVP during those times. And if you are undertreated with steroids, you may find that the opposite happens. So there are important interactions between the adrenal gland and other endocrinopathies. Special concern is during surgery. So we usually prep patients prior to surgery, which is a huge stressor, by giving them hydrocortisone before surgery, continuously during the procedure, and for 24 hours after the procedure. And then our autoimmune polyendocrine syndromes, so APS2, APS1, and then a lot of these that we don't see very frequently in pediatrics. We do see IPEX syndrome, obviously, which is not on this list. So in the among the APS syndromes, for APS1, you're going to have greater than or equal to 2 of the following conditions. You'll have mucocutaneous candidiasis, hypoparathyroidism, and or Addison's disease. And usually they appear in that order for APS1. You'll have the candidiasis and the hypoparathyroidism first. The hypoparathyroidism usually occurs by the age of 4 to 6, and the Addison's disease may follow by the age of 10 after. So we usually routinely screen these kids every year for their HPA axis to make sure that they're maintaining adrenal gland function. APS2 may include Addison's disease along with any number, really, of other endocrinopathies. And we don't see this one as frequently in kids, but it's seen much more frequently in the adult world. And the 2 most frequent comorbidities are autoimmune thyroid disease and type 1 diabetes. And then you can see other categories here that we don't really see in children very much either. So to compare APS1 and APS2, the 2 most common polyglandular endocrine diseases, APS1 can occur in infancy or young childhood, and it's caused by a defect in the AIR gene, not necessarily associated with any particular HLA haplotypes, and you can develop asplenism, so you have to think about the child's asplenism when they reach the age of immunizations, and a small but significant percent of them can go on to develop type 1 diabetes later in life. In APS2, again, you'll see older onset. Multiple generations are often affected. It does have an HLA association. It doesn't have a defined immunodeficiency, and still about the same percent can be affected by type 1 diabetes. So about the AIR gene, so the AIR gene is a transcription factor that you guys have probably studied much more than I have, that is important in the thymus, master regulator of ectopic expression of peripheral tissue-restricted antigens. And AIR gene knockout mice will mimic the human disease. So they exhibit widespread organ-specific autoimmunity, ovary, retina, testis, and stomach. And here's a picture showing autoantibodies to different organs in green in the AIR gene deficient mice. So AIR allows for the expression of antigens to which T cells are negatively selected, so that if it's functioning, you'll get fewer self-reactive T cells. Just to go back a moment, so chronic candidiasis is associated with disease of the mucous membranes of the skin, the scalp, and the nails. And they'll often have thrush or persistent, unremitting diaper rash caused by yeast. And some of them can have super infections with other bacteria or fungi. They have, if you see this, then you have to at least give some thought to whether they have another whether they have other endocrinopathies or autoimmune disorders, particularly if you see vitiligo in the presence of mucocutaneous candidiasis.
These people are pretty sick usually.
They can get pretty sick, yeah. And it's really hard to predict. We have some patients who for years just have autoimmune hypoparathyroidism, which of course we treat with calcium supplementation and vitamin D3 or calcitriol, and they have nothing else. Some patients go on to develop autoimmune lung disease, autoimmune liver disease, autoimmune gut disease. Really, every organ is affected, and we actually experienced the loss of one of these patients in recent history at Children's Mercy.
Well, I took care of one when I first got here and lost that one too.
Yeah. So for APS1, unusual manifestations, but manifestations that can occur, are multiple pituitary hormone deficiency, including growth hormone deficiency, and delayed puberty from lack of gonadotropins. Other unrelated autoimmune diseases unrelated to the endocrine system, like rheumatoid arthritis and Sjogren's syndrome. Hematologic manifestations can occur. Ocular disease can occur. You can get nephritis, bronchiolitis, autoimmune liver disease, even myocarditis. And you can get metaphyseal involvement that can affect the growth plates and create deformity. So we avoid live virus vaccinations in these patients, and if splenic atrophy is present, then we have to monitor closely for response to pneumococcal vaccine. So Schmidt syndrome is type 2, and as mentioned, these patients will more often have Addison's disease followed by some other endocrinopathies. Can include Graves' or hypothyroidism, type 1 diabetes, celiac. You can see hypogonadism, alopecia, and then some other non-endocrine disorders. You can see the range of HLA associations among these diseases.
You always see like HLA DR4 and DR3 and all of that, but can it become more specific than that now that we have more detailed HLA typing available?
Yeah, that's a good question. I haven't seen any data related to the autoimmune polyglandular syndromes, but I haven't exactly been looking either. So with type 1 diabetes, I think we know the most about more specific typing.
They have some in this article. They like to break it down further from HLA, DR3, and 4. Like they have the.
I might ask you guys for a copy of that article.
It goes out to like DRB1 *03.
Yeah.
Oh, okay.
For APS.
Yeah.
Yeah, right here.
Good.
Well, at some point we're going to have gene sequencing of everyone.
Yeah.
And you'll know exactly what HLA type everyone has, and that might allow you to better predict who's going to be at risk of developing these things.
We're not that far away from it at our own hospital.
That'll be really cool.
Yeah.
So we'll spend the remainder of our time here talking about type 1 diabetes because it's a really big topic and obviously an important autoimmune endocrine disorder. So you have to think about 3 different mechanisms that are important to the development of type 1 diabetes, which are genetic, susceptibility, the autoimmune mechanisms, and environmental factors. And so those are displayed by this diagram here. And, okay, good. So I like to show this. This is from the Barbara Davis Center in Denver, and this gives us kind of a natural history for type 1 diabetes. So you're born with a certain beta cell mass. If you looked on the y-axis there, we would say that the peak of that, where the plateau is, would be 100% of your necessary beta cell mass to achieve euglycemia. And you're also born with some genetic predisposition. So that may be your particular HLA makeup or other genetic makeup. And then along the way, you are exposed to some environmental trigger that causes the proliferation of self-reactive T cells. And that environmental trigger may occur anywhere during your young life, and that occurs at a time when you probably are maintaining 100% of your beta cell mass, so you don't really have significant loss of beta cell function for that. So after you trigger the T-cell autoimmunity, then you trigger the production of humoral autoantibodies, and those include insulin islet cell autoantibodies, which we refer to as ICA512, IA2, the anti-GAD antibody, which is the most common epitope, and the insulin autoantibodies. And there's a fourth antibody now that is determined to be pathognomonic for type 1 diabetes, and that's a zinc transporter 8 antibody. And so we have, as of last summer, added that to our profile. I don't think that there are any commercial labs doing it yet, but I think there are several that are scrambling to get it up and running as an assay.
Do we do it here?
We're getting it done at Barbara Davis. So they're the, one of the groups that discovered. Then you'll progress after you become antibody positive, and you will lose what we call the first phase insulin response. And so instead of seeing how you produce insulin and regulate your glucose on an oral glucose tolerance test, this is done by an IV glucose tolerance test, so that we can see in the first minutes after IV glucose what your insulin production looks like. And then you become glucose intolerant on a 2-hour oral glucose tolerance test. And then when you've lost about 85 to 90% of your functioning beta cells, that's when you have clinical onset of the disease, and the patient will, of course, present with polyuria, polydipsia, hyperglycemia, and if they're unlucky, ketoacidosis. One important thing to note about this diagram is that while I don't have it up there, there is some evidence that up to 80% of kids diagnosed before the age of 13 with type 1 diabetes will have positive antibodies detectable during their first year of life. And you're obviously not losing beta cell mass necessarily during that time, although we do have a few kids that are diagnosed less than 1 year old. Usually the diagnoses occur after 6 months, and very rarely do they visit type 1 diabetes if it's diagnosed before 6 months. It's usually neonatal diabetes, which is genetic in nature. But 80% of them will have positive autoantibodies, and the natural history of those autoantibodies is that they're there, and then they disappear, and then they reappear when you trigger the T-cell autoimmunity. And the mechanisms for that are really unclear, why they would be present so early in life when you're not having active T-cell upregulation and loss of beta cell mass.
Any thought about making that like into a screening test?
Yeah, so there's a lot of work now to identify biomarkers that might predict the onset of type 1 diabetes before you see humoral autoantibodies. And I believe that, I can't remember if it's Finland or Sweden, it might be Finland, screens everybody. And you know, they of course have national health care and a much higher incidence than any other nation to support that. But people are also looking at demethylated DNA from beta cells as a biomarker. People are looking at insulin RNA in the plasma and serum as a biomarker.
Of course, you have to get those beta cells, which is probably not a trivial...
No, it's not from the beta cells. You actually just test in the blood. So demethylated DNA that has some of the fingerprints of having come from beta cells, so on the insulin gene, you can detect in blood. And there are 2 papers that actually just came out in the last 4 months on this as a biomarker.
If you have that, can you do something about it?
Well, yeah. So we'll talk about why would we want to predict. So let's go into the genetic susceptibility in a little more detail. If you look at certain HLA haplotypes, you'll see that there is a 1 to 15 incidence type 1 diabetes lifelong versus 1 to 300 in the general population in the U.S. And if you look at family members, in family members you will see that maternal offspring may have a 1 to 50 incidence or risk, while paternal offspring have a different risk, which is very interesting. And that there's some concordance. So among monozygotic twins, you see that the incidence can be 1 in 3. This is risk by the age of 20 years in the general population and among relatives. There's definitely heritability to this. If you look at the worldwide incidence of type 1 diabetes among children less than 14 years old, here is where you'll see that Finland has one of the highest incidences along with Sardinia, and the U.S. population is one of the highest outside of those nations, and you can see that places like China have an extraordinarily small incidence. And there is, in some places like Sardinia, a sexual dimorphism in the incidence. So here's the incidence of type 1 diabetes from 1965 to 1996 in Finland, showing that there has been a steady rise among all age groups, which is really fascinating because we currently have absolutely no idea why the incidence of type 1 diabetes is rising worldwide. 3 to 5% per year is what it's been calculated at, and you can see it not just in Finland and Sweden, but also in the U.S. And in Germany, the incidence has been going up.
And that doesn't have anything to do with like obesity and the type 2 diabetes. It's a different type of thing.
Completely different beast. This just gives you a more refined view of Finland's numbers, not to indicate not just is the incidence rising, but the rise is accelerating. The percent of cases, the relative percent increase, you can see is different across age strata. While the incidence is rising in all age groups, it's actually rising the fastest in the youngest age group,
which eventually will become older age groups.
Right. This just briefly goes through hypotheses for the development of type 1 diabetes. So first you have to have protective or susceptible MHC with cross-reactive peptides being presented, and then co-stimulatory signals, and then you have to achieve inflammation and target organ killing to get diabetes. And I just throw this up there because it's really the framework with which we think about preventive therapies for type 1 diabetes. So I was at Kansas City's JDRF Gala, the Juvenile Diabetes Research Foundation, on Saturday night. And just to give you an idea of the amount of resources that are going into curing this disease, Kansas City alone raised $1.54 million on Saturday night. And so multiply that by the number of cities that have such fundraisers. So if we look at environmental triggers, we have a number of viruses that have been implicated. We have some dietary factors like vitamin D status that have been implicated, and some heavy metal toxins that have been implicated. A very important area of interest right now is the gut microbiome and the gut immune system. So early exposure to cow's milk may be associated with an increase in autoimmunity. There are contradictory data out there about that. Breastfeeding could be protective in that instance. And then there's also some association between vitamin D deficiency in the mother and the onset of type 1 diabetes in infants. And, there are some studies that have looked at vitamin D supplementation, and I think this verdict is still out on that.
What about this talks about cereal, and I think it says it up there too. Do you guys make recommendations? I mean, we always make it in pediatrician thoughts, it's until 4 to 6 months, and it kind of sort of leads along the same thing. Is that something?
Well, usually they're coming to us after they already have type 1 diabetes, so we don't get to make that recommendation.
Say
but as a general
pediatrician,
pediatrician, we always said wait until after 6 months.
like do the same thing.
Yeah.
I didn't say before
It says
3
there-
months or after 6 months.
Yeah, well,
Or after 7 months.
After 7 months.
yeah, or after
higher
7.
risk.
Yeah, they have a higher risk for having autoimmune.
Yeah.
Pretty interesting. Yeah. Some people don't really see anything.
So important to note is that, this is an incredibly complex disease with a lot of factors inputting into your risk for the disease. And we're probably going to find that any particular viral exposure or any particular dietary exposure is going to have a small effect size. And so that's why it's so difficult to say with certainty whether any of these particular factors are causative. But these are some of the viruses for which there have been epidemiologic associations. We've already talked about this, so I'll skip over this. But one or more antibodies, this is important to note. So the important point for this slide is that autoantibodies for type 1 diabetes are present in 85 to 90% of new onset patients. But the reverse of that is that 10 to 15% don't have antibodies at diagnosis. And so we sometimes screen them a year later or 2 years later to see if they have developed autoantibodies. And that's obviously an important principle for all endocrine autoimmune diseases, is that even with autoimmune thyroid disease, you may not have a detectable autoantibody in a small percentage of patients. To make things even more complex, 10 to 20% of patients with type 2 diabetes can have detectable autoantibodies at diagnosis. So you really have to incorporate this information into the entire clinical picture to make a diagnosis. This is just a picture showing the islets of Langerhans, which are where the beta cells reside to make insulin. And you can see that if you stain for insulin on the left, you'll see a lot of insulin-producing cells. Also important are the alpha cells and the delta cells. The alpha cells are also known to be diseased in type 1 diabetes, so you get a defect in both glucagon and insulin-producing cells. And glucagon, of course, is a counter-regulatory hormone to raise your glucose. The incidence of other autoimmune diseases is increased among those with type 1 diabetes. Obviously, autoimmune thyroid disease is the most common, but you can rarely have some others. Celiac disease is the second most common. Just to refresh your memory on the characteristics to distinguish type 1 and type 2. There is not a single genetic locus for type 1, but there are some hotspots there. And for type 2, I think that there are loci on so many chromosomes that we can't even name them. There's 50% concordance in twins for type 1, but an incredible amount of concordance for type 2. Type 2 diabetes, in contrast to type 1, is a disease first of insulin resistance, tissue resistance to insulin, along with a relative insulin deficiency. So while some individuals may be just fine dramatically increasing their insulin production to overcome the tissue resistance, some patients reach a plateau beyond which they can make no more insulin. And for both of these diseases, because remember in type 1 diabetes you're losing beta cells as well, so it's kind of like the economy, when a company lays off 20% of its workforce, the other 80% still have to do 100% of the job. So those 80% of cells that are remaining are further stressed because making insulin is an incredibly stressful job. I don't know how accurate this is, but I heard an islet transplant surgeon say at the ADA meeting last year that your beta cells consume 1 million times more oxygen per minute than your skeletal muscle. and 10,000 times more oxygen per minute than your beating heart.
We're working hard.
So it's a very small mass that is regulating global glucose homeostasis. In the last couple minutes, we get to prevention of diabetes. And for primary prevention, we want to prevent the onset of the disease before there's any detectable loss of beta cell mass. So we stop it before it really happens. And in secondary prevention, we want to prevent it in this phase, again, before the clinical onset of the disease, but after there has been some detectable loss of beta cell mass. And an interesting conundrum that we have in the field is that it's really, really hard to measure functional beta cell mass. So people are working very hard to find some way to non-invasively measure beta cell mass. Our stimulation tests and OGT and oral glucose tolerance tests, they're really not sufficient to tell us what your mass is. Notable is that for a long time we thought that the autoimmune destruction of beta cells meant that they were dead and gone. Now we know from the Joslin diabetes study, I forget what they called them, there were people with diabetes for 50 years or more, and they were like the gold medalists, gold medalist study. They have found that a significant number of those people still have very significant amounts of beta cell mass, but it was not functional beta cell mass. They were completely dependent on insulin. And so it brings up the notion that the cells may not be dead and gone, they may just be shut down, and that if you could find the right cocktail of immunomodulators, you might be able to resurrect them and have them produce insulin.
Or maybe there's a mutation in the insulin-producing gene that has allowed that cell to proliferate in preference to those that are making insulin, because they can grow faster if they're not making insulin, so they might take over.
Mm-hmm. I'm not sure that there is any evidence for or against that, but it's
be able to take those cells out and sequence them and see what's going on with those cells.
The immune modulators that have been tested for type 1 diabetes prevention include anti-CD3, thymoglobulin, alpha-1 antitrypsin is ongoing right now, a GAD vaccine, oral insulin is probably one of the first ones, anti-CD20, and now there are a whole lineup of additional ones. I'm happy to say that we've actually been involved in each and every one of these clinical trials in pediatrics in our center. The TrialNet natural history study is a really important study because for primary prevention, before you actually see detectable loss of beta cells, or secondary prevention, you want to be able to identify candidates. So you're not going to go around just giving everybody immune modulators to see if you can prevent the disease. You want to find those who are at high risk, and this study identifies them. So this study takes siblings and first and second degree relative of people with type 1 diabetes and screens them for the antibodies against type 1 diabetes. And if they have positive antibodies, then they are followed every 6 months with an oral glucose tolerance test so that we can track the progression of the disease. And these people become, if they have positive antibodies, the candidates for prevention studies. So there are two kinds of studies. There are post-prevention studies, or studies to alter the course after you've already got diabetes, because you still have 10 to 15% of your beta cells, and there is some evidence that preserving those benefits the patient by preventing complications, even if you have to take insulin. And then you have the pre-prevention studies to try to prevent the onset from ever happening. And that's what this says, basically. So the paradigm is to identify the subjects at high risk, detect autoantibodies, and monitor over time. So we screen first degree relatives, age 1 to 45 for antibodies, and second degree relatives up to age 20. Assess at 6-month intervals. The subjects get a benefit if they participate because there's less ketoacidosis. And of course they become the subjects for antibody trials. And these are the antibodies that we're looking at along with the zinc transporter antibody that I mentioned. So I just want to show you a couple of examples of how these trials are conducted I think I just have this in one more slide. So this is not actually a trial. This is actually from the DPT-1 study, which is a precursor to TrialNet, and it showed the time to diabetes as determined by the number of confirmed antibodies. And so you can see that if you have just one antibody on the survival curve, your progression to type 1 diabetes is less than if you have 2 or 3 or 4 antibodies. So 2 antibodies, and you're almost assured to have a greater risk of progressing over the next 5 years. So then when we get to altering the course, our criteria for immunomodulators to be used in pediatric human trials is that they have to be shown to be effective in animal models first. They have to have been shown to be effective in other autoimmune conditions first. That's important for pediatrics. And the safety has to have been demonstrated. So we screen by measuring C-Peptide. Remember, C-Peptide is clipped off of insulin when insulin is made, and that's how we measure residual beta cell function currently. Not the best way, but the only way we have. And the current studies that I mentioned to you that are ongoing are listed here. One includes metabolic control, because we think that your glucose control also interacts with the immune system to determine the progression of beta cell loss. And so here's an oral insulin study. Here there were 186 patients in each group, and you see that there wasn't a really significant effect of oral insulin until you do a stratified analysis and see that patients who had IAA antibody that was positive did get a benefit from that. So there were subpopulation who benefited from this. And that's going to become a really important theme as we progress with these trials, is that, you know, it's a pleomorphic disease, so there are going to be subpopulations who may benefit from certain therapies. The GAD-alum vaccine, again, they saw a significant protection from loss of beta cell function over the course of 30 months. The problem is that, you know, if you then take away the therapy, the treated group starts to look like the untreated group within 2 years. So that's where I'll stop today, and kind of a whirlwind tour.
Wow, very interesting.
That vaccine, how often was that given? Or
For GAD-alum, I'd have to go back and look, but I can email you that.
cereal?
Yeah, it was a cereal. Some of them are one-time doses, some of them are two-time doses, and some of them are given more often. GAD may have been given twice, but I have to look, to be honest.
But you said once you stop, then they...
Is it one of those like pre-prevention, so you give it to people who you like already
That was
have
actually-
antibodies, or just to people who,
That was actually given in new onset patients, that
like,
particular.
who all had GAD
Who-
antibodies,
that's right.
presumably, and then you gave it to them?
Yep. So the big push right now is to go from patients with new onset diabetes to patients in the TrialNet natural history study who are at risk for developing it over the next 5 years.
All right. Any questions from outside, or anybody have any comments or questions? Kind of a quiet group out there. All right. Well, very interesting. Thank you so much for this update. So you'll come back next year and tell us what the status is of these trials?
Sure. Yeah. If you guys have any questions after this, just feel free to email me.
Great.
Glad to.
Yeah.
And if you guys give me a copy of your assigned reading, I will make sure that I address some
Yeah.
of those.
You covered
You almost covered everything.
pretty much everything, and
Yeah.
that was really great.
But
Thank you so much.
We can email it to you.
Yeah.
All right. We're going to take about a couple-minute break, and then we'll be back, and Dr. Stengel will lead us in an allergy journal club. This conference is on allergy from Mercy Hospitals and Clinics in Kansas City, Missouri.
This has been an ACAAI production. To learn more about conferences on Lyme allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.